Hi, this is Lou Bridges. I'm the Physician-in-Chief and Chair of the Department of Medicine at Hospital for Special Surgery in New York City, and previously was at UAB for many years. It's my pleasure to present the RA2-DREAM Challenge, automated scoring of radiographic damage in rheumatoid arthritis. Shown here are the organizers of this challenge, including those at UAB, as well as IBM, University of Colorado, and then with very strong support from Sage Bionetwork. So I want to thank all of the organizers and those who contributed to the infrastructure. So rheumatoid arthritis is a chronic disease of unknown cause characterized by inflammation in the joints in the early stages shown here. It can affect up to 1% of population worldwide and has an effect that has been seen in every ethnic and racial group. About 2/3 of patients are women, and the end stage, as shown here, is progressive joint destruction with loss of function and disability, and it has been associated with premature death. The target joints, as shown here, typically the wrists and the hands, as well as the feet, with the metacarpal phalangeal joints and proximal ulnar phalangeal joints of the hands being affected in up to 90% of patients, and the metatarsophalangeal joints in up to 90% of the patients as well. This is a demonstration of the development of an erosion, a normal joint, the same joint shown later with early erosion, and then shown here a marginal erosion of the bone, as well as joint space narrowing shown here. The target of inflammation in RA is the synovial lining, which is normally a very delicate membrane, and shown here are more marginal erosions as well as joint space narrowing. This is a demonstration of what we try to avoid with using treatments for rheumatoid arthritis. This is a normal left hand where you can clearly see the gray lines between the joints representing the cartilage in the metacarpal phalangeal joints and proximal ulnar phalangeal joints, as well as multiple joints within the wrist itself. And with end-stage rheumatoid arthritis, there's complete destruction of the cartilage with deformities of the hands, and as you can imagine, chronic pain. So there's an urgent need for automated scoring of rheumatoid arthritis-associated damage for multiple reasons, and I'll mention briefly what the need is in the realm of research and what the need is in the realm of clinical. So radiographic damage is an important outcome measure in rheumatoid arthritis, but it's difficult to study because of issues of feasibility. So current state-of-the-art scoring involves visual inspection by an expert, which requires extensive training and expertise. Often 2 readers are required to assess inter-observer variability, and this is time-consuming, expensive, and non-scalable. So for large studies of large numbers of patients to have outcome measure of RA being radiographic damage, there's very significant hurdles to doing that. The clinical need is when clinicians such as rheumatologists see patients in the clinic, they rely often on damage reports from the radiographs, and these often are very short and sometimes very confusing, such as using words such as possible or mild or scattered. Many clinicians do not have access to musculoskeletal radiologists who are used to reading hand and foot films in rheumatoid arthritis and other types of arthritis. And then biologic drugs that we use to treat rheumatoid arthritis are often indicated, many of them are indicated for prevention of progression of structural damage, meaning X-ray progression in patients with RA. But this progression is difficult to assess quantitatively by clinicians. So having an automated way to score these films would provide a quick and easy and quantitative measure of damage for clinicians to help guide their treatment decisions. Shown on the next slide is the state-of-the-art scoring system for assessing rheumatoid arthritis damage. And you can see here the target joints that are typically affected by rheumatoid arthritis, which are used for the scoring system, which includes both erosions, as shown on the previous slide, and narrowing of the joint space, as shown previously as well. And these are the joints that are scored in the hands, wrists, and feet. The maximum score is 448 for very severe damage. For completely normal films with no damage from rheumatoid arthritis, the score is 0. And you can see how this breaks out for erosions scores in the hands and feet and joint space narrowing scores in the hands and the feet shown here. So most patients with severe disease will have anywhere from a score of around 100. We almost never see anything much above 100. And often we see a score of 0 because not every patient with rheumatoid arthritis develops joint damage that can be seen radiographically. The radiographs that were used in this challenge came from two large studies. The NIH-funded Consortium for the Longitudinal Evaluation of African Americans with RA, in which we enrolled 1,100 African Americans with either early RA or in the later state in the Clear 2, any disease duration. We obtained films in Clear 1, which was early disease, at baseline defined as less than 2 years disease duration, as well as at 36 and 60 months of disease duration. X-ray films in Clear 2 were obtained at only one time point. All films were scored by the Sharp-Van der Heide method by Dr. Van der Heide's and her colleagues themselves. We also studied, had available films from the NIH-funded Treatment Efficacy and Toxicity in RA database, which were about 200 patients with established RA who were enrolled before starting treatment with either methotrexate or a biologic agent, and these were enrolled at 9 different sites, and hand and foot films were obtained before treatment and after treatment, and also scored using the Sharp-Van der Heide method. And as I mentioned before, not all patients developed damage, so we had a large proportion of these films in the challenge that were normal, which was helpful for training the algorithms to learn what is a normal film. So shown here is the goal of the challenge. You can see here we had a training set and a test set. The goal was to develop an automated method to quickly and accurately quantify the degree of joint damage associated with RA using images of the hands and the feet. Sub-challenge 1 was to predict the overall amount of damage in the target joints. That would include narrowing and erosions in case that someone could analyze the films without segmenting in particular joints. Sub-challenge 2 and 3 relied more heavily on the algorithm segmenting the joints, telling the computer which areas to look in. And sub-challenge 2 was to come up with an algorithm that would accurately assess joint space narrowing in these target joints, and sub-challenge 3 to use the image to predict the joint erosion scores. And so these were the 3 challenges, sub-challenges that were part of the RA2-DREAM challenge. So what was unique about this DREAM challenge? It provided data scientists to use machine learning to develop an approach to segmenting individual joints, to interpret 2 parameters, narrowing and erosion, in the context of joint deformity, and to create overall damage score. The automated quantitation of this damage would have a great impact on the use of structural damage in research studies, such as those studying genetics or epidemiology or biomarkers, but then also for the clinical aspects, which I'll talk about in a second. So the other thing is our films were already available at the time of the start of the challenge, and because we're in pre-competitive space, all the results would be shared initially with investigators at Clinical and Translational Science award sites from the NIH, because part of our funding came from them. And all data would be made publicly available. Also, the success of the challenge would incorporate these scores could potentially incorporate into the health records of patients to help guide clinicians to make treatment decisions to prevent further damage and disability. And these lessons could be applied to other imaging problems of importance in other diseases. And then I want to thank our two funders, which was the CD2H from the University of Oregon Clinical and Translational Science Center, and from the Bristol Myers Squibb Foundation. So now I'll turn it over to Jake Chen to talk about the next part of the challenge.